Good morning, everybody. We'll get this session started. So welcome to this early morning session. It seems quite a few of our colleagues are still finding their way from breakfast, so hopefully they'll catch us along the way. But we've got an interesting session lined up for you this morning, focusing on education. Of course, the cornerstone of everything that we do is on the basis of a sound education in our medical space. It's my pleasure to welcome our first speaker, Professor Wayne Morris. I'm sure all of you are familiar with Wayne. He's the immediate past president of WIFSA, but he's had a very active education role on the international space as the chair of the education committee and then the director of programs for WIFSA. So he's very well positioned to talk to us about educational aspects. He's currently based in Christchurch, New Zealand, and his topic for today, or his angle on the talk today, is looking at education as the most powerful weapon. Of course, those iconic words from our icon, Nelson Mandela, suggesting that this was the weapon with which we could change the world. So Wayne, we look forward to your thoughts, and welcome.
Good morning, everybody. The advantage of speaking first is that I don't have quite as big an audience, so that's very nice, but I'm sure some people will filter in during the rest of the session. It's wonderful to be back in Africa. It's wonderful to be back in Johannesburg, because this is where I really started my global health journey in 1988. In 1988, I was a final year medical student, and I spent a month at Hillbrow Hospital, not far from here, and then 2 months at Shongwe Mission Hospital, which is between the Kruger Park and Eswatini, as it is now called. That was a very formative time of my life, and it certainly helped to kindle an interest in some of the issues of providing healthcare in low-resource environments. My wife and I have had a wonderful couple of weeks before this Congress, and we not only have seen some sights in South Africa, but we went up to Botswana and also Victoria Falls in Zimbabwe. So here are just a couple of photos from our safari in Botswana. We got to see lots of amazing animals and arrived at this kill where a leopard had killed a impala early in the morning. Amazing place. So as Dean said, the title of my talk comes from a statement made by Nelson Mandela. Education is the most powerful weapon which you can use to change the world. And the mission of WFSA is uniting and empowering anesthesiologists around the world to improve patient care. I really like that word, empowering, and I think there's a nice link between education as an empowering tool and our mission, which is to empower anesthesiologists. So this is the basic structure of my talk. I'm going to talk about why we should educate, I'm going to talk about who we should educate, and how we should educate. I'm the immediate past president of WFSA, as Dean said, so I'm not actually in the leadership group at the moment. So I hope I don't say anything to upset the current leadership, which is sitting over here. The first question is, why do we need to educate? This statement comes from the Lance Commission on Global Surgery, which published its report in 2015. 5 billion people out of 7 billion people do not have access to safe anesthesia and surgical care when needed. And this was a game changer. This report was a game changer for us at the time because it put anesthesia and surgical care on the global health agenda. But it also highlighted the issues that we face with providing care worldwide. And one of the main reasons for this statistic is that there are not enough trained anesthesia professionals worldwide. This graph is taken, or this map is taken from the 2015-16 Global Anesthesia Workforce Survey, and it shows the density of physician anesthesia providers or anesthesiologists in the world as it was then. So red corresponds to less than 1 per 100,000 population. Dark green corresponds to more than 20 per 100,000 population. And you can see that there are some very low numbers of anesthesiologists in sub-Saharan Africa, other parts of Africa, and parts of Asia. With incredible disparities around the world. We've actually repeated this survey, and the latest survey was published in Anesthesia and Analgesia earlier this year. But basically, the issues remain. Huge disparities worldwide, and I think also a vulnerable workforce, especially after the COVID-19 pandemic. There's some other work that highlights that post-operative deaths are actually a big deal when it comes to overall mortality. And this was an article published in 2019, which suggested that post-operative deaths are the third leading cause of death worldwide. And one of the issues that we have when talking to World Health Organization and governments is that often post-operative deaths aren't categorized in this way. They're categorized in terms of disease categories, or deaths are categorized in terms of disease categories. So the number of deaths related to surgery and anesthesia is actually hidden in the data. And there's some more work that suggests that there are more deaths due to poor quality care rather than lack of care. This is work by Margaret Crook and colleagues. Margaret Crook's a physician in Boston, the United States. And she looked at mortality data from 137 low and middle income countries and looked at the number of amenable deaths. And these are deaths that should have been avertible in a good quality health system. She found that in these 137 countries, there were 8.6 million excess deaths. And from further analysis, they classified 5 million of these deaths as due to poor quality care and 3.6 due to non-utilisation or lack of access to care. So we can see that, she suggested that there are more deaths due to poor quality care. I think for anaesthesia and surgical care, we could make an argument that the underlying causes of mortality might be different, and there might be more deaths or a higher proportion of deaths due to lack of access to care in some countries. But I think the most important point here is that it's a combination of we need access to care, but we also need good quality care. So it's really about quantity and quality. So safe care depends on having adequate numbers of well-trained providers. Who do we need to educate? This quote has been attributed to many people, but the most consistent author of the quote is this man, Lao Tzu, who's considered to be the father of Taoism. And he said, "Give a man a fish and he'll eat for a day. Teach a man to fish and he'll eat for the rest of his life." And this, to me, highlights the importance of teachers. An organisation like the WFSA, and also the societies that you're members of, needs to concentrate on supporting and developing leaders and teachers. And we've got a real problem in resource-poor countries where often the people that need to be educating, they need to be managing departments of things, are really stretched because of all the clinical work. And in some places, there are just simply not enough people to teach. Or sometimes people have diverted away from clinical work and are trying to do the management stuff. So this is a quote from Marcel Durieux in 2014. "Those in clinical practice are overworked, and the few that might be involved in teaching have to devote most of their time to administration." So it's a real problem because we don't get those people being able to help develop the workforce by teaching and leadership. And this is really one of the ideas behind the WFSA Fellowship Program. These are short subspecialty attachments all around the world, and the program was started in 1996. Since that time, we've trained 452 fellows, and these fellows have come from 67 countries around the world. There are currently 23 trainees. Unfortunately, during COVID, there was a real hiatus because we had to stop the training programs, but we have now restarted these programs. And I think people always think of these programs as being about transfer of knowledge and skills in subspecialty areas of practice. But actually what is really important is that these fellowships help to develop professional networks, and they help to develop the leaders and teachers. This is a photo I took in 2015, which shows the 2 African fellows who are currently who were then based in the Ganga Hospital Fellowship Program, which is a hospital in Coimbatore in India. The leader of that program is Dr. Bala Venkat, who's in the centre of the photo, and he is the current secretary of the WFSA. With him are Dr. Ahmed from Nigeria and Dr. Nyandwi from Rwanda. And both those doctors have returned home after their fellowships, and they have contributed amazingly in their home countries. WFSA conducted a survey of fellows who were finishing their fellowships or had previously done fellowships, concentrating on what are some of the things they learned or examples of how the fellowships have helped them to be leaders and how they'd helped them to be teachers. Now, I'm not going to go through all of these, and I'm going to struggle reading the text there, but I'm just going to highlight a couple of things there. I really can't read the prompt. I mean, the top one at the left. One of the examples of leadership was leading interdisciplinary teams, mentoring junior colleagues and advocating for change. The one on the bottom, it provided an opportunity to influence others by example. And I'll leave you to read the other ones. But I mean, I think these are real world examples of how people have used their fellowship time to actually go back to their home places and to make real change. I just want to spend a couple of slides on a really thorny question, and there are some countries, going back to that map, where there are almost no anaesthesia providers, no anaesthesiologists. There's nobody to lead change and develop workforce. So I regard this as a bit of an elephant in the room, that you do have some places it's really difficult to even plant the seed and get it growing. So just as an example there, a few years ago, with the help of Dr. Keith Thompson and Dr. Dutty, who's at this meeting, we established the Liberia Anaesthesia Capacity Building Program. That was in 2018. And that's where we took some Liberian doctors and they went to Kano in Nigeria and completed the West African College of Surgeons diploma. It's incredibly resource intensive to train people from scratch like this in another environment. But we actually did manage to train a few people. But you can see the number of organisations involved: the Liberian Medical and Dental Association, the teaching hospital itself, the Nigerian Society. So I'd like to acknowledge the Nigerian Society for all the work they've done with this program, and also a number of funders and other supporters. So these were the people that started the training, and I think 3 people completed that training. And we hope that they are going to be the leaders and teachers that will establish the anaesthesia workforce in Liberia. Okay, finally, how do we need to educate? I think we need education that is targeted, flexible, and accessible. Here's a brief classification of some of the WFSA's educational offerings. So we have the fellowship programs. We're going to hear more about those during the rest of the session. We have short subspecialty courses like SAFE, EPM, Essential Pain Management, and other courses. we have meetings like this one in the World Congress, and we provide scholarships for a number of people to attend some of these meetings. And then over the last few years especially, there's been real development of online learning. Many of you will be familiar of Anaesthesia Tutorial of the Week. We also have a publication called Update in Anaesthesia. We've seen a growth of webinars in the last few years. There's the WFSA YouTube channel with a whole lot of videos, and we've also produced specific information and guidelines from time to time. I hope many of you are familiar with the SAFE courses, Safer Anaesthesia from Education. This was co-developed with the Association of Anaesthetists of Great Britain and Ireland, and it started with Safe Obstetrics and Safe Paediatrics. Now, this is an example of targeted education because we know that a real burden of work for us, and especially in low-resource environment, is the subspecialty areas of obstetric anaesthesia and paediatric anaesthesia. And during COVID, we were already developing online resources, but we certainly had to develop them faster, and we're now seeing more of these courses being developed online in real time, and also there are a lot of resources that are available for people to look at later. Here are some of the other short subspecialty courses in more detail. I was very closely involved with the development of the Essential Pain Management course. I co-wrote it with a doctor called Roger Gook in Western Australia. There's a simulation course called VAST, Virtual Anaesthesia Simulation Training. We've just launched recently the Perioperative Patient Blood Management program. There's a suite of courses called Inspire. The courses there include clinical teaching and clinical leadership. And there's another course called Primary Trauma Care, which has been going on for a while, and Safer Long Bone Fracture is an example of a more specific course which was recently taught in Malawi. Wherever I've travelled in the world, I've come across people who have used Anaesthesia Tutorial of the Week. And it always interests me that people in high-income countries can use this resource as well as people in low-income and middle-income countries. On average, we produce a new tutorial every fortnight. We now have over 500 tutorials translated into a variety of languages. And these tutorials are really great practical resources. The WFSA website address is www.wfsahq.org. And please just have a glance at the website, and that will give you a much better idea of the resources that we have available and also our other activities. So here are the key points. Safe patient care depends on having adequate numbers of well-trained providers. So remember, it's that balance of quantity and quality. We need to be developing and supporting leaders and teachers. We need this snowball effect where these leaders and teachers can go on and train others. They can develop a quality workforce, and that workforce will be the one that provides excellent care for patients. WFSA as an organisation needs to provide targeted, flexible and accessible educational resources for colleagues worldwide. That's what we're doing, but it's still a work in progress, and you will see more and more resources available over coming years. And just a reminder that education is empowerment. I'd like to finish with another quote from Nelson Mandela, which I discovered the other day, which doesn't relate specifically to education, but I think is just a great message for us all. May your choices reflect your hopes, not your fears. Thank you.
Thank you so much, Paul, for such a nice presentation. And education is power. I think he's put that right. And actually, I'm one of the beneficiaries of WFSA fellowship. And WFSA is like a father to anesthesia. It has a lot of resources. You cannot go anywhere without having to go back and check what is in WFSA. Our next speaker is Professor Ibironke Desalu. She is a professor of anesthesia and a consultant pediatric anesthesia at the University of Lagos Teaching Hospital. She is involved in undergraduate and postgraduate training in anesthesia. She is the president of Pediatric Anesthesia Society of Nigeria and coordinator of Safe Pediatric Training Nigeria. She also has worked as a part of numerous SMILE training and a lot of other amazing stuff that she has done. Her area of subspecialty interest is included in difficult airway, blood management, and cardiopulmonary resuscitation. I would love to welcome Professor for a talk in pediatric subspecialty.
Good morning, everybody. And I always wonder why we applaud before I've said anything. Is it for the outfit or for just showing up? You know, so anyway, I'm here, and I'm here to talk about education in Africa, pediatric anesthesia, subspecialty. Yeah, okay, so yes, I do a lot of other stuff, postgraduate training, pediatric anesthesia society, SMILE training, and pediatric anesthesia training in Africa. So we start off with what is the magnitude of the problem? We're talking about children. Africa is the second largest continent in the world, and approximately 40% of our population are children less than 15 years. By March 2024, it was estimated that we had 650 million children, and that is a lot. Of this population, Bika mentioned that 85% will require surgery. It is also predicted that the population of children in Africa would rise to 650 million by the year 2055. So we have a lot of children. And the trend in childhood mortality is moving from, in the low and middle income countries, is moving from infectious diseases to things like congenital disease and trauma. So we have a lot of patients that are going to come to anesthesia, not only for the surgical procedures, but also for us to give support for diagnostic, radiological procedures as well. So we're going to get a lot of children coming in requiring anesthesia services. So we know we have a lot of children in Africa. So how are we doing regarding our anesthesia? How have we fared in morbidity and mortality? And there are two big studies that come to mind. The first is the pediatric surgical outcome studies, which demonstrated, that's a mistake that was done in 2021, which demonstrated that there was an unacceptable high mortality in our children for 5 conditions that were investigated. And most of the mortality were in neonates. Then we have the African surgical outcome studies, the PEDS study, and they recruited a lot more patients, 8,625 patients in 31 countries, and demonstrated an 11-fold higher mortality in these countries than in high-income countries. And then we have a lot of other local studies that show that we have high mortality with our children. Many of these studies have identified multiple factors that are responsible for this high mortality. And they range from late presentation, because a lot of our patients live in rural areas, to social factors like access, lack of health insurance, finances, as well as, very importantly, a low workforce for anesthesia, as Wayne showed in his graph. Who should provide pediatric anesthesia services? Well, many societies agree that any fully trained anesthetist would have undergone sufficient experience in anesthetizing children and may therefore continue to do so for as long as their clinical practice exposes them to children. But anesthetists providing care to a wider and more complex surgical procedure, a surgical child, would need to have acquired additional advanced training in pediatric anesthesia. What attributes do we want in a pediatric anesthesia fellow? Well, they must be knowledgeable in the field. They must have adequate skills and competencies to do the job well. They must be able to inspire others and train others and demonstrate qualities of a good leader. They must advocate for the specialty among hospital management, government, everywhere. They must talk and talk and talk about pediatric anesthesia. They must have empathy for the children. They must understand the children, and they must understand the parents of the children. If you don't have that, then the passion for pediatric anesthesia is not there, and it becomes a chore. To many of us, pediatric anesthetists is a way of life. It's not a job. We could do it free, but please don't tell our employers. The timing and duration of this training should be left to individual regions. Each region should decide when they want the training and for how long they want the training. And there are differences. Could it be pre-fellowship, that means within the residency training like is done in Ghana? Could it be post-fellowship, that is after residency training like is done in Nigeria? How long should the training be? Oh, by the way, July 17, I just put it there because it's my birthday. How long should the training be? Should it be 6 months, like WFSA does? Should it be 12 months, like PATA does? Or should it be 24 months, like some other institutions do? So all these have to be determined by the local region because they know what their needs are. I believe that any training less than 6 months will not have enough exposure in things like critical care and regional anesthesia. So my belief is it should definitely be more than 6 months, maybe 1 year. Where should we be doing this training? Well, ideally, it should be in specialized children's hospitals, but many countries don't have that. And if you do, you're lucky. Otherwise, any hospital that has a substantial load of pediatric patients, including neonates. Remember the PED-Surg study said we did very badly with neonates, so we need to do more neonates, so that when we go back to our centers, we are good at neonates, and we can bring up those numbers. They should have neonatal and pediatric critical care services. They should be able to provide facilities for sedation and NORA, and they should be able to conduct complex pediatric procedures. Having said all these things about the training institutions, many of us know that one institution may not have this, so we should be prepared to split our training between institutions. So how many cases do I need to do to be an expert or to be good at anesthetizing children? We know that the caseload of an anesthetist affects our rate of complications. PED-Surg said we had a lot of complications. In fact, our patients died. But the more we do, the better we become and the less complications we have. That has been said as far back as 1997. So the recommended caseload may vary, but I find that after looking through many training facilities, institutions, it ranges between 250 to 300, 350 that you need to do to be proficient or to have said that, oh, fine, I've done enough children. But they must include neonates and also sick children of ASA 4 and 5. What should we be logging? We should be logging procedures that require additional skills that make us feel that, yes, I can do this in pediatrics. Difficult airway, regional, invasive monitoring, all these should be logged. As well as the variety of surgeries that we do, acute and chronic pain, resuscitation, critical care, transfer. We should also log our learning experiences. Where are we learning from? Lectures we attend, lectures we give, because remember, we want to be trainers, not only skilled, but we also want to be trainers. So we need to log all that in our logbook. Are assessments necessary? Oh yes, competencies must be seen to have been achieved one way or another. It can be formative or summative. Summative assessments are done at the end. What can we really do? Some places will have a dissertation, and so we prefer formative assessments. And this we want to look at direct observational procedural skills, as well as entrustable professional activities. These are the things we want to look at. It takes a lot of time to get this done, but this is the only way that we can be sure that our fellows have achieved the competencies that they set out for. This is an example of milestones that I got from the Royal College of Thailand, and we should be aiming for level 5. In other words, the fellows should be competent in that particular skill and should be able to teach others less experienced that skill. Now, who develops the curriculum for pediatric anesthesia specialization? All this logo you see here are institutions that have developed various curricula for training of pediatric anesthesia in Africa, and we're not doing too badly. This is, I thought Wayne would talk about this. This is the WFSA fellowship map showing all fellowships offered in the worldwide. He mentioned that. There are presently 11 fellowship sites for pediatric anesthesia with a capacity to train 22 fellows. Most fellowships run for 6 to 12 months, with the exception of Serbia, which runs for 3 months only. Looking in detail, these are the WFSA training sites in Africa. There are 5 sites for 13 fellows. Now, I'd like to talk about something that I'm involved in as well. I did declare in my disclosure slide that I was involved with PATA. Pediatric anesthesia training in Africa is a unique collaboration between Vanderbilt University, Nigeria, Zambia, Uganda, Kenya, and Ghana. It started in 2022 with a grant from funders in the United States. Its aim is not to only produce specialists, but trainers and advocates for pediatric anesthesia. Training takes place over 12 months, except in Ghana, where it is over 24 months, because they work with the Ghana College. There's a 2-week boot camp that provides ALS, PALS, and MEPA training, as well as safe PEDS to the fellows. The training also has a PICU block, and PATA has presently graduated 21 fellows to date. And I will share a short video about PATA at the end of my talk. Currently, pediatric anesthesia subspecialization takes place sporadically across Africa, as seen. We have 1 site in North Africa, we have 2 in the West, 3 in East, Central, and Southern Africa, and 1 in South Africa. Compared to the rest of the world, apart from the US and the UK, we're not doing too badly. In fact, some countries don't even have pediatric anesthesia subspecialization training. So at the first glance, well done. But when we try and reconcile this with the number of children we have, we find that we still have a lot to do. Looking in more detail, the WFSA site in Morocco has trained 3 fellows, but is presently on hold. And I was told, Wayne? I'm not sure. I was told that Tunisia may be in the making. I'm not sure about that. That's gossip. Apart from WFSA training, there are also apprenticeship programs that run in Morocco in the various hospitals for about 3 months after the residency. They can do pediatric anesthesia. In West Africa, the Ghana National College started their program in conjunction with PATA, and they presently have 2 fellows in training. Nigeria was established as a WFSA site in 2016, but unfortunately, we only had 1 fellow. Recently, through PATA, we have trained 4 more fellows in Nigeria, and 2 have started the 3rd cohort. The training in the National College and the West African College of Surgeons the National College in Nigeria and West African College of Surgeons that cuts across the whole of West Africa is yet to be implemented. But the West African College of Surgeons is also working closely with PATA to try and get a curricula that will be good for our region. Because as I said earlier, the region should be responsible for the training and the contents of the curriculum. The University of Nairobi is our flagship in Africa, and I commend them because they have trained 24 fellows in pediatric anesthesia since 2013 from 12 countries in Africa, including Kenya. In fact, most of the trainers in Africa trained in the University of Nairobi. The training is supported by SPA, WFSA, and Impact Africa, and is also a PATA training site. The University of Nairobi has, Uganda and Zambia are also PATA training sites and have trained, Uganda has trained 5 fellows and PATA has trained 4 fellows. The College of Anesthetists of East, Southern, and Central Africa, CANEXA, is soon to commence their own 12-month post-fellowship training. South Africa has an apprenticeship-like program through the University of Cape Town and the Red Cross War Memorial Children's Hospital, and have trained 10 African fellows from 8 countries so far. So they train and they've gone back to their country, which is commendable. A certificate of completion is awarded at the end of the training. The program, however, is not recognized or certified as subspecialization by the host country, and something needs to be done about that. The picture in French-speaking sub-Saharan Africa is, however, poor, as shown in this paper, that no country runs a subspecialization training program in pediatric anesthesia in French-speaking sub-Saharan Africa. We also have short trainings. Safe Peds, PALS, and MEPA are run throughout the African continent. Building faculty for specialization. As I said earlier, PATA has added on 21 new pediatric anesthetists to the core of faculty that we have. The initial faculty had been trained in the University of Nairobi, WFSA, and a couple of them had personal arrangement in the UK. Trainers should not only be competent in clinical work and research, but they must also provide learning in the most conducive manner. And I want to mention Impact Africa. It's an online faculty development course designed for physicians involved in education at teaching hospitals in low-resource settings. It's a 12-week course that teaches teaching methodologies, course planning, simulation, assessment, mentorship, leadership. It's a very, very good course. So anyone that wants to learn wants to get better at teaching should attend the course. I attended it and I found that it was great. So, looking at all these empty spaces in Africa, how do we fill in these empty spaces? One, we can work on establishments that are already there, collaborations that are already there. West African Health Organization, the WFSA, ARS section, postgraduate colleges. We can interact and work with ourselves because these are already established connections, so we can use that as a platform to increase training in the West Africa, in the African region. We have specialist and subspecialist societies, especially subspecialist societies in Nigeria, in South Africa, in Kenya, and there's a new pediatric anesthesia African Society, I think I got it wrong, Pediatric Anesthesia Society of Africa that is being incorporated, and we're going to have a nice dinner or something to inaugurate ourselves pretty soon. And so we can use that as a forum to discuss among ourselves. It's very difficult for specialists to cross from one country to another. There are too many blocks. We should make it easier. So I can go to Cameroon and give Raymond a hand, and Rebecca can come to Nigeria and teach us a skill without having to go through all this registration and stuff. So we should try and make things easier, and we can work on these bodies to do that. Or maybe PATA could be the answer. Okay, yes, I'm a bit biased, but pediatric anesthesia training in Africa, maybe we can stretch out to areas that don't have pediatric anesthetists. We could work with the postgraduate colleges. I know PATA is working with the West African College of Surgeons. They're working with the University of Nairobi. They're working with the Ghana University. So we could work with other postgraduate colleges because we have faculty. We're turning out faculty. And we could work with them so that they could go and establish curricula to train more pediatric anesthetists for the region. We can't have good training if we don't have drugs, if we don't have equipment, and so we need to work with our pharmaceutical companies, we need to work with our equipment companies so we can get these things to work with. But of course, funding needs to be there, and funding is a whole new talk, and I'm sure no one wants to hear about that here today. So in conclusion, pediatric anesthesia subspecialization training in Africa is promising. We need to collaborate. There's need for international collaboration, and we need to advocate to our government for support. At this point, Yes, thank you very much for your attention from Pediatric Anesthesia Society of Nigeria and Nigeria Society of Anesthetists. And I'd like to play you a short video about PATA, if you could permit me to do that. Thank you.
We had a child that had traveled 9 hours by road with something stuck in their airway.
My wife calls me in a panic. Daughter has been bent, I don't know what to do.
This was a 3-year-old who had swallowed a coin.
21% burns.
A 7-year-old girl.
Child was less than 6 months.
The beep is going down and it doesn't seem like everyone is concerned about the beep.
He said, no, you can't do that.
I'm here, I have the knowledge, I have the expertise, but I just can't reach everyone.
You could lose the child.
They just arrived in the nick of time.
A lot of people don't understand what we do.
Such moments made me think like maybe there is this gap that we need to fix.
You know, it really shows how much your services and skills are needed.
Thankfully, the child survived.
The child did survive.
We lost the child on table. If we had had a pediatric anesthesiologist, I think maybe the outcome would have been different. Yeah.
In the last 10 years, Nairobi has trained fellows from over 11 countries in Africa, and all of them have gone back to their countries to be the only pediatric anesthesiologists for their country. And that is how we came up with the idea that we need to train more people in the places where they are.
This is our second year of the Pediatric Anesthesia Fellowship for PATA. We have fellows from Zambia, Uganda, Nigeria, as well as Kenya coming through.
My name is Sompwe Mwansa. I'm a pediatric anesthesiology fellow under the Pediatric Anesthesia Training in Africa program.
I'm Ronald Bisegera, a pediatric anesthesia fellow.
Dear Dr. Chalwe Mutesa Mwewa, thank you for your recent application for the PATA Zambia WFSA Fellowship Program. I'm happy to share your application was successful. The WFSA wishes to award you with a fully funded position on the PATA Zambia program. Please respond to this email by Wednesday, 12th July, confirming you would like to accept the fellowship. I did not wait for the 12th of July. I responded immediately.
So I think that in terms of where anesthesia lies on the landscape of Africa, and in particular Zambia, we are definitely on the back foot. Surgical training in Zambia has been happening for almost 4 decades. Anesthesia is only 10 years old that we've been training general anesthesiologists, and we're in our first year of training pediatric anesthesiologists.
So we envisioned developing PATA. We had been speaking about how do we increase the ability to train and to have more leaders in pediatric anesthesia. I think many of us recognized, and I guess were alarmed, looking at the numbers out there.
The World Health Organization estimates that 50% of the surgical population will be under the age of 18 by 2030. That's in about 6 years from now. So half our patients are going to be children, and we need to have a proper approach to treating them.
Then we have a significant pediatric population. We can't treat them like adults. They are not adults. They're a special population. They require special need. Having this training now says, okay, we have to have guidelines. We have to have protocols. And then for the critically ill, this is how to care for them. This is how to look after them.
My expectations is going to learn how to offer safe anesthesia for complex pediatric surgeries. I'm hoping to gain more skills in training others. And then advocacy for better services, because even when you have the skills without the equipment, it's still difficult to offer safe anesthesia.
Not everybody has access to, a simulation lab as well as the equipment, because it really does take a lot of sophisticated equipment that you need to be able to manipulate depending on the scenario you have.
Getting to work in different environments, getting to work with different pediatric anesthesiologists, being taught by renowned pediatric anesthesiologists. PATA really gave us a broader understanding of what it means to care for pediatric patients.
If everything goes as intended, I hope that we will have, in 5 years, at least 10 pediatric anesthesiologists in Uganda. That means better training for just the residents coming out of the universities, better training for the non-physician anesthesia providers who still provide the bulk of anesthetics for patients, especially children in most sub-Saharan countries. And then, of course, we'll have more pediatric anesthesiologists who will be able to work in the roles of clinician providers. If you have numbers, then it allows people to serve in other roles, right? So sit at the leadership tables and make decisions, get involved in policy making, as well as, engage in more research in the field and help us to use data that comes from our own settings.
I come from a place where anesthesiology as a specialty is young, and because of that, you find that you really need leaders and educators in different specialties for the specialty to actually grow.
Being one of the first people who's qualified under this program means that I'm in the unique position to be able to speak about this program, the benefits of this program, the need of this program.
What I would look forward to is seeing that almost every African country has a training program for this pediatric anesthesia fellowship.
When you've got a happy team, outcomes are better.
It's increasing the safety and correcting mistakes that are being done. I'm very, very hopeful the PATA program is going to improve lives and make lives better.
Isn't it amazing how education and training is uplifting our whole continent? Amazing work across the continent, so well done to that team. Brilliant. Our next speaker is unfortunately not with us. He's had an emergency to address, so we'll hold that over and we'll move to our subsequent talk on our program. And this is going to focus on cardiac anesthesia training across the continent. It's my pleasure to welcome my co-chair, Angela Mohoza. She's based in Tanzania as a cardiac anesthesiologist and is the director of the only cardiac facility in the public sector in Tanzania. So Angela, welcome.
Good morning, everyone. Once again, it is an honor to be here today and meet all the geniuses of anesthesia from all over Africa. But I want to thank my God for his grace and favor that I'm here. I don't take it for granted. And cardiac anesthesia is such a wide topic, but I'm supposed to say something about it. As I said, WFSA is responsible for everything that I have and who I am right now. So I'm going to present about cardiac anesthesia. I'll talk a little bit about our program as an example, and I hope to inspire the young generations to come. We heard the talk from the previous speakers that workforce is a big issue for us. Yeah, but let's see where we are going in the next coming days. So as I've been presented, my name is Dr. Angela Muhozia, cardiac anesthesiologist from Tanzania. This is a public institute. It's called the Jakaya Kikwete Cardiac Institute, and it's the only cardiac center in our country at the moment. And we have 66 million people who need the cardiac service. So I'll start a little bit with a story. This is common for all of us. Everybody, we come from different backgrounds before we go for anesthesia specialist. And then once we are done, you are declared now you are anesthesia specialist. How do you feel? You feel so excited, you feel like I need to show now, I know what am I going to do. You want to show the difference from the center that you have been working, now you want to go back. But our seniors, Dean, Professor Wine, I don't know if Dr. Edwin is around, Ambassador Mpoki is around, yes? So these are our teachers. They have something else in mind. So they'll start asking you very strange questions. What type of an anesthetist do you want to be? They can give you just a week and start asking you questions. If they are so generous, maybe a month. Okay, they want you to say something. So where are you going? Where is your direction? Okay, they'll ask you, what is your area of interest? Even if you try to run away from the questions, they'll keep on coming and asking and asking. You need to start thinking about your career. You need to upgrade your CV and all these things. So when I was preparing this talk, I went through one of our cardiac anesthesia fellow, Dr. Ogvillier. She was doing her cardiac anesthesia fellowship in Cambridge, and she had exactly the same kind of story. And I said, oh, this is common for all anesthesiologists. But it's not a bad thing, it's a good thing that we are supposed to grow. You have become a specialist, then what? You have seen from the pediatric anesthesia part and the other parts that will be coming, we have to go somewhere after you have done with your anesthesia specialist. So when I was reading through WFSA updates, I saw a history which was very interesting. It is a common history, but I thought, let's catch up on this one. So I think most of us knows this slide. This guy started 400 before Christ, when everybody was thinking what kind of medicine, what kind of ingredient we can help people to be operated without feeling any pain, without being aware of the pain. And these are some few which were documented, but there's a lot which have not been documented, and this depends on the culture and the area this person is coming from. There are some very strange technique I went through, like carotid compression. You make the patient lose consciousness for a while so that you can operate. Or some have been given a bullet to bite so that they can tolerate the pain. But all this, were some of the stuff, the former anesthesiologist thinking, what can we do to assist this person who needs surgery to be operated? And because of that, surgery was so terrifying those days. And it was kept as a last thing to do when you're trying to save somebody's life. So this public announcement is very common, everybody knows, 16 October 1846, where Sir William Morton demonstrated ether anesthesia. As you can see, the group of, I think this anesthesia specialist, the generation of those days, interested to see what is ether doing. And they discovered that at least it caused the loss of awareness and also less pain for this patient who was operated to remove the lump under the jaw. But what is the message that we are getting here? What was in the mind of the anesthesiologists of those days? It was always about the patient. It was always about the safety. So as anesthesiologists, we usually think of going away from the topic, but now we are always coming back. It's patient safety. That is our priority. That is what we should think about. Now, the concerns that they had, as I said, is the pain that the patient is feeling. It's the awareness that the patient is feeling. But science told us more, that there is more to it. There is what is called stress, okay? Also, as anesthesiologists, we have to think about it, and a lot of other comorbidities that patients are having that are affecting their recovery. But remember, the main issue is how safe is this patient when they're being operated. Now, we cannot run away from this topic. I know that there are no surgeons here, but the growth of anesthesia cannot grow by itself without the growth and advance in surgery. So the way surgery is improving, also anesthesia is improving. Advancement in surgery goes hand in hand with advancement in anesthesia. So as you can see now, surgeons are thinking exactly the same thing that we are thinking. Okay, how safe can surgery be? So they're trying to have less blood loss, less pain, all this early recovery to make sure that the patient goes back home early and safe. We are also doing the same. So if they are thinking of minimum invasive surgery, we are thinking of localized regional pain management. We are thinking of regional anesthesia, something that will only help the patient. But our focus is early recovery, safe anesthesia, and that the patient goes back home. Even the complexity of surgery that we're having right now. We are having transplant surgeries. Now we're having cosmetic surgeries. Anesthesia also has to grow in the same way. So as I said, the patient factor and the surgery factor together, both of them are focused in safety, but also a better outcome for our patient. We can only assess it by improvement in mobility and mortality. So who is a cardiac anesthesia? Cardiac anesthesia, this is a physician. We heard about pediatric. Okay, now we are talking about cardiac anesthesia. This is a physician. It's an anesthesia specialist who decide to advance and take cardiac as a subspecialist. So on the picture you can see on my left-hand side that those are the only anesthesiologists, cardiac anesthesiologists that are present in my country. So the first gentleman, they told her that is His Excellency, the Ambassador Mpokuli Subisia. He can just stand and wave, please. So, and the third person from the right, that is Dr. Edwin Lugazia. I'm not sure if he's around. So these are the first generation of cardiac anesthesia in Tanzania. They were trained and they started the program of cardiac. I'm lucky, by the grace of WFSA, to be the third generation cardiac anesthesiologist. And we have Dr. Alex, who is the fourth generation of cardiac anesthesiologists from my country. And we have more who are coming. We have Dr. Faraji and the rest of the team who will be going for cardiac anesthesia just to improve the workforce of cardiac in our country. But apart from being the specialists who provide anesthesia for patients who need cardiac surgery, but also they are consultant for patients with cardiac conditions who are being operated in other programs. So I say, my talk is basically about the training to try and convince more young anesthesia specialists to go for cardiac. There's a lot of things that maybe can draw you back, but I thought, let's go back to the basics. Okay, so most of us are trained as a specialist in anesthesia, and you get the general basic knowledge of anesthesia. These are the fundamentals. These are the grounds that we get as anesthesiologists. They don't change. They are exactly the same. And whatever you do, if you have a good basic, you can provide a safe anesthesia wherever you go. And as anesthesiologists, we should be proud of these basics. And also, we should not look down on these ones, even if we become specialists in something, because at one point in time, you will have to go back to the basic, no matter how much specialist and experienced you are. So the training program for most of the doctors is we go for our first degree as doctors, and after that, some will go for 3 or 4 years to become anesthesiologists, and then we need to do additional training to become cardiac anesthesiologists. So these are the basic principles of anesthesia, which I don't want to go in details, but it's the knowledge of pharmacology and physiology that we get during our basic training that makes anesthesiology stand out. There is no physician who is good as an anesthesiologist in pharmacology and human physiology. But also we have other knowledge in perioperative management. We have the skills that we get, like intubation, the rest. We also have techniques which are special for anesthesia. We know all of them. But what is very important is the communication skills that makes our patient feel safe. When we counsel and tell them, I'm going to put you to sleep, and somebody is going to cut you. So that trust is a skill that we get, and it's the basic skill that all anesthesiologists must have. To have a good anesthesia, you must have a good communication skill, and you should be able to make your patient feel so relaxed and happy that they can allow you to put them to sleep. If your patient is anxious, as an anesthesiologist, you have to go back to Professor Desalo and ask, what can I do? What should I do? Because you need to have the confidence of your patient. And this is one of the skills that we get when we are doing general anesthesia. So as I said, this is one of the strengths that we have. So we should not undermine this part. So these are some of the subspecialty that we usually do as anesthesiologists. Some of them, I'm sure we are going to talk about them in different sections during this conference. And some will be coming as anesthesia is growing, as I said. Now, what is so unique about our training cardiac? This is more specific to cardiovascular system and is incredibly detail-oriented. So the cardiovascular system is very complicated, but once you get the training, all is going to be easy and you'll be able to provide safe anesthesia to your patient. But this one also, there is a very necessary and very important information about the pharmacology and the physiology of cardiovascular system. As I said, we know the whole body physiology and pharmacology, but that is a lot. Now, when you go specifically for cardiac, then when you are being trained, as I was trained, that is where I got more details about the cardiovascular system. And then you'll be able to play with everything that is happening in the cardiovascular system. But this training is very special because it's more about the skills and the competence that you're going to get. So this is not theoretical. You cannot become a good cardiac anesthesia without doing the practice. You need to practice. You need to do a lot of patients. So the pediatric specialists, they have their numbers, but also for us, 100 is a minimum per year for you to become a good cardiac anesthesia. So you have to, for you to be able to catch up with the skills. But also the additional part in cardiac anesthesia, this is mandatory. There are different invasive monitoring systems that you have to learn how to do it and how to interpret it. In the morning, we had a very interesting session about AI in hemodynamic monitoring. So all this is coming from the invasive monitoring. But as I said, cardiothoracic anesthesia is also a very stressful. So we have patients who are very stressed, but also it's a very stressful situation. So if you are very trained very well in the basics, then you will not have any issues dealing with the patient with a cardiac program. So now, how much time do we need to train a cardiac anesthesia? I looked around in different countries. They have different kind of programs, but majority of them, they have a minimum of a year, up to 2 years to train you as a cardiac anesthesia. Now, why? Why should you go for cardiac anesthesia? If you are still thinking, if your supervisor is still asking you the first question I said, why? What are the reasons? Why can't you choose? So the first thing is the opportunity to save. In my country, before I go to my country, these are data from WHO that death from cardiovascular diseases per year is around 17.9 million. And 75% of them are coming from the low and middle income countries, means Africa, we are part of it. But the sad thing is 80% of these deaths are preventable. You can only prevent if you detect the diseases early and you intervene early, which is not happening. Why? Because we don't have enough people to do the intervention, to detect and to treat these people. So you can check, this is my Tanzanian data, but you can look at it as a green pasture, but think about your country. How many people do you have in your country? And we know that out of every 100 children that are born, 1 is born with a congenital heart disease. And 25% of them, they need intervention within 1 year. So this is our data that we need 5,000 children. They need intervention, cardiac intervention every year. But we can only attend 7% of them. As I said, we are only 4 of us. and we need more people to go and train. But this is not only in cardiac anesthesia, but also in other parts. So think about your country. How many people needs cardiac intervention? So you can go. This is an opportunity to save somebody's life. And this is the data only for children. So we also have a burden of rheumatic heart disease in Africa. If you add that, it makes even this data worse. So think about cardiac anesthesia as one of the fields that you want to go and take. Another thing in cardiac anesthesia is the diversity, that the clients that we get. Most of these patients, they don't just come with a cardiac condition. All the stuff that you see around there, if you look in details, they have it. They have a kidney issue, they have a lung issue, they have a vascular issue, they have coagulopathies. It's just a whole book in one patient. So this person who is going to go for cardiac anesthesia will have a diverse knowledge on how to manage this, because you cannot operate on a patient if you have not optimized just the endocrine part, just the kidney part. So for you to be able to optimize, you have to go to the details, know how, what kind of medications, how are the interactions, whatever. So cardiac anesthesia is one of the person who has a lot of knowledge about other systems apart from cardiac. So for young generations who wants to learn, who wants to know more, cardiac should be your choice. Another thing is the multidisciplinary nature. So when we are doing cardiac surgery, it's not a one-man show. So you have a group of people who are dealing with one patient at a time. So I've just mentioned a few of them on the next, on the second bullet. You need a cardiologist who will diagnose. You need a perfusionist when you are doing the surgery who will take care of the heart-lung machine. You need nurses, good nurses. You need a good ICU team. You need physiotherapy. And you need the patient themselves and the relative, their instructions that they have to do. So for you to be able to be successful, then you need to be able to work as a team with all these members at once and make sure that the patient is safe. So we go back to communication. So this is one of the things that you will be good, you will be forced to be good. So when we are doing cardiac surgery, there are stages. You need to be talking to your surgeon continuously. So we call it closed loop communication is serious and is real in cardiac surgery. But one other thing that has been observed is that there's a gap of competence. So when you are an anesthesia specialist, you are trained to deal with the cardiovascular issues that are caused by anesthesia. Whatever kind of anesthesia you're giving, you have hypotension, you have whatever. So you are dealing with the cardiac anesthesia issues. But when you become a cardiac anesthesiologist, you have a patient who has a bad cardiac, has a bad cardiovascular system. And you have to manage both the cardiovascular complications of anesthesia, but also the cardiovascular condition. So this is one of the very important parts that you're going to help this patient and you're going to save the patient. And because of that, you need the invasive hemodynamic monitoring part. And this is one of our trainees who's being taught how to put a central line. So as I said about the monitoring, so we have the basic monitoring in normal, and also have the monitoring in cardiac, which is advancing and improving as time is going by. So in cardiac anesthesia is a field where you'll have a chance to explore a lot of new technologies that are coming. I was happy that today I was exposed to the AI. I'm sure a lot is coming. Now we have a direct echo guidance when you are doing cardiac surgery, but you have ECMOs, we have a direct bronchoscopy that we do, we have intra-aortic balloon pump, we have a lot of things that are coming in the field of cardiac. So if you are serious and you want to know and learn things, new technology that are coming very fast, go for cardiac anesthesia, and then you'll be able to see all this. All right, as I said, it's advancing and progressing, so this is one of the areas that you can learn how to do cardiac. But why I thought it's important to talk about this, because most of us, our exposure is very little. So we are exposed for a very long time, rotating in cardiac department. Some goes up to 6 weeks, some maximum 3 months. It's not enough to make a person be interested to do cardiac. And when you hear, they say it's a longer surgery and a lot of other things, so most of the people will be discouraged. but also the type of facilities that we have. We have facilities, not all of them will be able to provide cardiac. So if you are not exposed to cardiac, then you cannot get an interest in cardiac anesthesia. So you need to have access to a facility that will be able to provide cardiac. So maybe this is an area that WFSA and other members can help us to make sure that we expose our anesthesiologists adequately so that they can be interested to do a profession of cardiac anesthesia. But the last one is career choice. What is your choice? What is your interest? Because you should do something that you like, because you'll be good in it. Don't just do it as an opportunity because you're looking for a job, but you'll be very good if it's your choice and it's your interest. Okay, I said I have to put this. If I don't put it, it's not fair. I said so many good things about cardiac, but there's also a little bit of issues about cardiac that you need to know, but you should not be scared. This, I think, is all over in all the specialty. But it's extremely demanding, so you need to work 24/7. You cannot run away from cardiac, okay? So we usually know what time, I hope we have cardiac anesthesia here, apart from Ambassador Mpoki. We all know when we are going back, yes. We all know just what time we are getting in. We are not sure what time we'll be going out. Anything can happen. We'll be told, oh, you are going back on bypass. All these things can happen. So it's really demanding. So you need to love cardiac anesthesia for you to be able to do this, especially in transplant and all these major surgeries. But I don't know why it is very less in women, but we need to encourage more women to come. Because one of the data I saw, out of 7,000 cardiac anesthesiologists, only 300 were women. So women, we need to work up, but we are proud that we are part of us. You can see my data. We are 4 of us. I'm the only lady there. So we need to work on this side also to encourage women to do this. I know it's tough because we have other things that we need to do and we cannot work 24/7, but our patient needs us, and I know women are good. We can provide the best service. Another thing is cardiac anesthesia. I don't know if it's the whole anesthesia or it's cardiac. Lack of visibility. It's like you just see the patient before surgery, you see the patient while you are scrubbed, and once you send the patient to the ICU, the patient does not even remember you. If you ask the patient, what is the name of your doctor? They will tell the surgeon. But who is a true physician here? So this is another thing that is this is also discouraging, but just go for cardiac anesthesia if it's your passion and if it's in your heart, because what you have done actually is bigger than what the surgeon has done, because just one mistake and the patient is gone. So as I said, it's very expensive. So you need a dedication, commitment, and focus. But also you need to learn how to be calm and stress-free, because actually if you work for more than 10 hours, you're going to be very stressed. And so you need to be okay to calm down your surgeons. Cardiac anesthesiologists understand me. The surgeons, sometimes they just lose it. So you are the person who has to take care of the atmosphere or the OR. Okay, so in summary, cardiac anesthesia training is regarded as a hands-on, skill-oriented anesthesia specialty. It's very attractive, intellectually stimulating as a career. But most of the skills that are acquired need to be exercised. My personal advice, this is not from WFSA, this is my personal advice. Yes, choose cardiac anesthesia, but first, please, please, please identify your skills and interests. And Pia, also, I spoke a Swahili word, narrow down your options, okay? Set achievable goals. You can go and become cardiac anesthesia after some time. So make sure you take it slow until you reach to a person that you want to become. But at the end of the day, just make a decision. Otherwise, your supervisors will keep on nagging you, who do you want to be? Because they don't want to see you practicing general anesthesia for 2 years. They want you to do something else. Thank you. So that is my presentation. And I have a picture here. This is our nurse. She's called Sister Aimana. So one day, one of my anesthesiologists called a child to put to sleep. And luckily, this baby did not want the mother. So she wanted this nurse to take her, and the nurse just say, okay. She just put an African way of killing babies and put the baby on her back. Thank you so much.
Thank you very much, Angela. You can see her passion totally evident in cardiac anesthesia, isn't it? It's very refreshing. We'll move to the last talk for this part of this program. It's my pleasure to welcome Mary Nabukenya from Makerere University in Uganda. She's active in the pediatric anesthesia space. She runs the PATA program there. But today she's going to talk to us about innovations that have come about in African education. Thank you, Mary.
Thank you, Dean. Good morning, everyone. So, I didn't check to see how this works. Let's see. Okay. So, as Dean said, I have a big bias, and I'm a member of the PATA program. So it will show up in my talk as we go, but I will endeavor to talk about other things that are happening on the continent. And this is my outline. I'm sure a lot of us have spoken to each other, and many times when we speak to our colleagues, you realize that there's so many things that I struggle with that someone else is struggling with. And a few times you realize that maybe the other person has figured out some innovative way to solve this problem. But I will never know this if I don't talk to people. We will never know what other people are doing if we are not talking to each other. Yesterday, I attended a meeting for the African Regional Section, and Professor Bisola stood up and very passionately was speaking about the fact that this is not the time for Africa to be divided along different lines. It's not North Africa, it's not Southern Africa. We're all one Africa. We need to form a community to find solutions for ourselves. Through the past conferences, there are some themes that have been resonating. It's innovation, it is let us find solutions for Africa. So we've learned, or we are learning, that what works elsewhere doesn't necessarily work for Africa. Some statistics, and some of it you have seen before. The Sustainable Development Goals, the target for maternal mortality rate is 70 in 100,000. And the number for the African region is almost 8 times that. Africa reports about 700,000 deaths due to cancer, and our outcomes are so poor if you compare them to those in high-income countries. Injuries due to trauma are among the top 10 leading causes of death in Africa. All these are things that I'm highlighting because they all are directly related to accessibility to surgical care. The African Surgical Outcomes Study, which all of us are hopefully familiar with, it showed that if you're an adult in Africa and you have surgery, your chance of dying from your surgery is twice that of someone in a high-income country. We also know that 1 in 50 women are going to die following a cesarean section. It's even worse for children in Africa. Nearly 70% of countries that were found by WHO to be vulnerable for the availability of healthcare providers that are needed for us to achieve the thing that everyone is talking about, universal health coverage by 2030. Nearly 70% of those countries are in Africa. We need to do something. We are all very familiar with this map. Africa is still red hot, and COVID-19 did not help this situation. If you think about the training programs, Professor Morris had a map, a quote that said, "What if there is no teacher?" If you look at the numbers of the training programs, we're not producing enough for the populations that we have. Now consider the subspecialties, right? If the pool from which we are getting these guys is small, it's going to be even worse for the subspecialty training. If you think about the fact that according to the ASOS studies, the biggest procedure that is done in Africa is cesarean sections, right? And then Professor Desalu highlighted the fact that we have a lot of children in Africa. And yet, before 2022, there were only 2 pediatric anesthesia fellowship programs, and then you have only 2 obstetrics programs on the continent. Well, some people have found some solutions, mostly as individuals, a few as institutions, to train elsewhere, maybe overseas, but that comes with a host of challenges. And one of them is you have to compete with a wide range of people, and as an African, the odds against you are stacked high. And then think about the cost of that. The funding could probably train at least 2 or 3 other people if they were trained nearer home. And then, of course, there's the differences in systems, the equipment that you have to deal with. The pathology is sometimes very different. You have to deal with cultural differences. And of course, there's the challenge and difficulty of being away from home. So what's the solution? What can we do as Africans to increase the numbers of specialists and subspecialists on the continent? A lot has been said about PATA. Again, I'm biased because I'm part of this program. But these are individuals that came together, different, they have different interests, they're from different countries, but they have one common interest, which is a perfect example of collaboration. It is something that everyone and so many people have been talking about, but collaboration is very powerful. It has gone beyond just individuals to include so many institutions, and some of them I haven't highlighted here. I'll talk about another collaboration that someone else has talked about before. In 2016, Liberia had no physician anesthesia providers. 8 years later, there's a blip on that map. There's one physician providing anesthesia in Liberia. And what brought this about? Professor Morris has talked about this already. But this is another example of collaboration, right? And thanks to the Nigerian Society of Anesthetists and the Aminu Kano Teaching Hospital, they have provided a space very close to Liberia where Liberian doctors can now be trained as anesthesiologists. If we want to create new programs for specialties, subspecialty training and training of anesthesiologists, the other thing that we need to think about is what you want the culture to be like. And when we talk about culture, what do you want your training model to look like? It's important that these training models should be collaborative. If we can design and create centers of excellence in certain regions, and then everyone else can learn from those, I think that would be a good thing to do. The other thing that we should consider is to try and create a culture of support and networks. Again, we know that there are places where there's one individual that's going to be maybe the obstetric anesthesiologist or the pediatric anesthesiologist or the critical care person. That person has such a huge burden that they carry at their workplace. If they have a network of people that understand their problems or their teachers or mentors to go back to, this would be very helpful for them, such that they're not carrying all this burden for themselves. They're not going to fall off that path a few years down the road. They have a network that they can tap into. And then we need to leverage the partnerships that we have. For the Liberia program, that partnership has been the Aminu Kano Teaching Hospital in Nigeria, because it has provided for them the infrastructure for learning. It provides teachers, it provides mentors. Professor Desalu has talked about this. For PATA, that institution has been the University of Nairobi Pediatric Anesthesia Fellowship Program. They have a vast amount of experience, over a decade, and they've trained people that have gone back to be leaders. And so this is a wealth of experience for us. We don't need to go through some of the pitfalls that they encountered. We know how to avoid those just because we're in partnership. We have heard about the WFSA, and we all agree that the WFSA has played a tremendous role in supporting both anesthesia programs as well as subspecialty training in Africa. The thing that you want to consider if you're starting a new program, either for subspecialties or for anesthesia training, is that they have a legacy of understanding different contexts, and they have the organizational structure that can support a number of programs. So that's something that you might want to associate yourself with. And then, of course, there's the different colleges. So there's Canexa, we have WACS, then different colleges in different countries. But these are institutions that are well established. People will trust an institution like this more than they will trust me if I decide to start a program in Uganda. So if you're looking for funding, if you're looking to advocate, it's so much easier to advocate with a big institution. It goes without saying that the training models we try to create need to be able to develop, to pass on the skills that we want the learners to develop. But the other thing that's really important is mentorship and leadership. A lot of people in Africa get into leadership positions very early in their careers, and so there's a huge need for mentorship training. And again, PATA has incorporated this impact global e-learning for the trainers, the faculty already, but also for the graduates from the program. Because we know they're going to be teachers, but even the teachers maybe did not get this kind of training before. And so this is a program that has been incorporated. You may be a lot more people might be familiar with the Inspire Through clinical teaching course. It's a 4-day course that is meant to make teachers, clinicians, better teachers. You cannot assume that just because I'm an anesthesiologist, I know how to teach. So it's important for all of us to have some sort of clinical teaching. The thing about Inspire is that it also incorporates some mentorship for the teachers. You have to think about the curriculum that you want to use to deliver the program that you've created. It has to be context sensitive. And when I say context sensitive, I do not mean substandard. But if you create a curriculum that cannot be translated into the area or the place where you're teaching, then it's not going to be very useful. You can still have you can have some desirable aspects added. And the picture here is one of the graduates from the PATA program, and she's using ultrasound to check for increased intracranial pressure. If you think about it, a few years ago, they did not have the capacity to do point-of-care ultrasound. But because someone has advocated for this, now they have this. If she had not learned this skill, then she wouldn't be able to do this. We have to leverage technology. In the PATA program, I speak a lot about PATA because that's what I know well. We have decided to use a blended curriculum. There are spaces where there are no teachers, or the teachers are too few, okay? But then we know there's a whole wealth of teachers out there. So we have the fellows are learning from their teachers immediately in the clinical space, but then they have these joint online classes with each other, but then you also get world-renowned teachers that have some time to spare, and they teach the fellows. And some of them are the world leaders in their specialties. You would never be able to get this if you didn't have the capacity to do that. They keep an e-logbook, and the advantages of that is that it helps you to track the students' progress, but it also helps them to track themselves. It's good for analytics and looking at some metrics, but it also forces the fellows to log their work. E-learning is something that a lot of programs are already using. Connexa is using this. They have an online module, e-learning module. PATA is creating one, and the beauty of what we're doing with PATA is it allows us to involve more people. It allows more people to, be part of this big thing that we're trying to do here. Simulation is something that is becoming increasingly a vital tool for training and skills development. I particularly like simulation for low resource settings because you can very easily customize what you need to do and achieve high realism with low technology. And so you don't need to spend tens of thousands of dollars buying one piece of expensive equipment. I have included some existing courses. This is just a few, but these are the ones that I know incorporate simulation. And if you're creating a program either for anesthesiologists or subspecialists, this is some of the stuff that you can just pick and take. You don't need to create new things. People have already done this. It's been tried and tested. Some people in this audience may have attended the SIM Launchpad course. And what it is it's a course that gives you the startup toolkit. If you want to go and start simulation in your hospital or in your institution, this would be a great course to attend. It's important to have champions, right? It's very difficult for many people. Again, there are places where there's no one in existence. There's no pain specialist, there's no regional specialist. And if you go back home and face the mountain that you have to climb, sometimes it's very easy to give up. But if you have people that can walk the talk and they believe very strongly in what they're trying to do, it is very important to support those people. But I want to tell this, a short story in this picture. This gentleman is called Dr. John Adabi. He did his critical care training at the Red Cross Hospital here in South Africa about 10 years ago. And he went back to his hospital in Ghana, and he's been at it for all these years. He has not taken a holiday. He's just been there working and working and working. Thank God for people who want to do better and availability of these positions. Recently, he was joined by Dr. Eugene Mati, the person on the left. And together, they're now running this PQ at the Comfort Anoche Teaching Hospital in Ghana. The amazing thing, the reason why I'm telling this story is because recently, the PATA program in Nigeria needed a place to send their fellows for their PQ rotation. Again, we have maybe 2 ICU programs on the continent, and South Africa is just too complicated. So that was not going to work. Guess who the solution ended up being? Their neighbor across the border, okay? So that person, the person that ended up helping, was Dr. John Adabi, the one champion that has been running this ship for all these years, and then he's recently been joined by Dr. Eugene, and now this is no longer an opportunity for just Nigeria. All the rest of us are starting to see this as the next potential thing. And guess what? I have a feeling this is going to be the next site for pediatric critical care training. We have to talk about funding. We cannot hide away from it. If you're going to run a program, a new one, you need to find some funds somewhere. If the government can give it to you, if your government can give it to you, that would be great. But you need to package your story right. Again, it helps to be affiliated with some of these institutions. If you have to go through the WFSA, I'm sure they will welcome a well-structured program. If you have to go through the colleges, it's so much easier to advocate and look for funding if you're associated with a well-known institution. And then, of course, the question of sustainability. How do we do this? I don't have the answers, but I can make some suggestions. If we embed our programs in already existing institutions, I think it will be easier for it to continue. If we figure out a way to make it self-funded, I think that will be great. But we have to show value for the programs that we create. And how do you show value? You need to collect data. If we can figure out a way to show the impact that our programs have on other people outside of us, but also it would be nice if we can get champions outside of ourselves. Maybe the surgeons, maybe the administration. It would be great, and that will help us a lot. In summary, we need to think about our African context and develop some innovative, collaborative, and context-sensitive and appropriate ways to solve our problems and to solve the problem of the anesthesia workforce on this continent. Ultimately, we need to do this together. Thank you.
Thank you very much, Mary. May I please invite the speakers to come up? We can have a bit of discussion. So one of the hats I wear is as the chair of the Education Committee of the Colleges of Medicine of South Africa. So, of course, we're constantly looking at how we can improve the system, and we are undergoing quite a bit of change at the moment. We're just in the process of revamping the curriculum, and as Mary was highlighting, it's very important that the curriculum is context sensitive and reflects what you want it to do. And that came on the back of a colleague's PhD that I supervised, where we showed that anesthetists in the country were not fit for purpose, according to how they viewed themselves and according to how we viewed them as teachers. So it's interesting that we're now needing to make this an iterative process to reinform how we train so that ultimately we want to get fit for purpose specialists out there. All right, I'm going to be, please, if you've got any questions, if you raise your hand up, identify yourself and throw it at the panel. But I'm going to be a bit provocative and ask all the panel members. You've heard lovely programs in cardiac anesthesia and pediatric anesthesia going as subspecialist areas. Should we be even thinking of subspecialist training in a region where we don't have providers at all, any providers? Shouldn't we rather be focusing on generalists rather than subspecialists? And I'm just doing that to be provocative. I'm an intensivist as well, so I'm a subspecialist.
Well, that's a good question. And in this day and age, I think we need to look beyond, we need to look beyond just the question of, do I have food on the table, right? It's a thing, it has to be about more than just food. It has to be about, can I get a balanced diet when I get food? So I think, yes, we have a problem of general shortage of the workforce, but we do have other problems that are going along with the general problem of the lack of the workforce. We cannot forget that a lot of our patients are children. We cannot forget that a lot of the surgeries that we're doing are cesarean sections, and the outcomes for cesarean sections are so terrible. Like, we have to figure out a way to address these problems alongside the the workforce, the general workforce problem. I hope that answers that question.
Anybody else wants to pick up on it? Please feel free.
Why can't we have specialists? We need subspecialists to train the generalists. They need to be there because as a generalist, you do children. You need someone to put you through doing neonates. We have such high mortality with neonates. We have 7,000 people in Tanzania needing cardiac surgery. I can't do cardiac surgery, and yet I am a generalist. So we need to train both the generalist and the subspecialist specialists at the same time.
I agree with that, and I guess it's really a question for our member societies, our national member societies in the African region. I mean, that's, you know, they're the groupings that understand the local context. I think we need to be doing both, though. That's my personal view. But it's bigger than just anaesthesia specialty training or subspecialty training. It's whether the countries are training enough doctors in the first place, whether they're training enough healthcare workers in general. And one of the problems we've had in global health and healthcare in general is that there's been siloed thinking when it comes to healthcare. And really, we always need to be thinking about anaesthesia and surgical care and the overall delivery of healthcare to patients. And our voice needs to be heard with our governments in our own countries.
So in the South African context, the only recognized subspecialty training is critical care. There is a program for pain management that we've put through the system, but it's still stuck in the processes and is being developed. And Duronko was asking about the pediatric setup. There has been an initiative to drive the development of pediatric anesthesia as a subspecialty, and that is being worked on currently. So yes, the question was meant to be provocative. I think we constantly use this, but I raise that because there's a sense politically when we were trying to put these subspecialties through that the country doesn't need, even South Africa doesn't need more subspecialists, they need more general doctors. And that was the argument that was being put forward. But as I'm saying, and as you've heard, we need the expertise. I mean, who do you go to when you need something specific sorted out? You don't go to the general builder to do your tiling, do you? You want a person who does tiling. Yes? When you want to build something specific, you want your carpenter to do that, rather than a general person. And that does become an issue. Of course, there are some other disciplines who have carried it to the extreme. You know, the orthopods, you get a subspecialist who deals with the left knee only, so that's the other extreme. I've seen two hands up. Rebecca.
Oh, I was first.
Is there a microphone that we can get here, please?
Can I go while Rebecca's getting her mic? Thanks, Dean. Because I've got the mic first.
Go ahead.
Thank you. Good morning, everyone. Mine is more, is it not on? Oh, you want to hold it? Oh, can I hold it? Thank you. Mine is more a comment than a question. It's a comment or an appraisal to the local organizing committee and to myself, to say that I feel the Congress has filled the cup that I felt was empty. I want to believe that it's the first time that so many different African countries are in one room, and that we're addressing pertinent questions and coming up with innovations and putting our issues on the table and learning from each other. So I really want to thank the LOC and for allowing the craziness to come onto the table. Prof. Langren, in the process, as we're asking questions, the solutions are there. If we think about a program such as Connexa, which we all brought onto the table as we were discussing this program, if a couple of countries can come together and form a coalition that trains their basic specialists. We need to be looking within ourselves because there are pockets in Africa where there's expertise. And as it has already been shown, in every region there's a champion. And the purpose of this Congress was that we should find each other. As regions, we should find each other and find the solutions within ourselves. And we brought the WFSA into the room because we're hoping that the WFSA will have answers to some of the funding questions or guidance in terms of finding each other that we need to do. Thank you.
Thank you very much, Palesa. I mean, the consistent theme you had from all the speakers was about collaboration. And that came out very strongly. And the point is well made that in a room such as this with people from diverse places, we need to collaborate to make it a stronger one. Rebecca.
Thanks very much, Dean, and thanks for the opportunity to address your comment. And I think the mistake that we make when we think about subspecialty training is that we're thinking that every child needs to be anesthetized by someone who's a subspecialist in pediatric anesthesia. Well, that's absolute nonsense. There are many, many children that can be safely anesthetized by a good generalist, by a medical officer who's trained in anesthesia, provided they've gone through some training in just the basics of looking after a child under anesthetic. What we're saying is that we need leaders and we need people to educate and we need people to develop the training programs who have got the advanced skills and the advanced knowledge that goes with the specialty of pediatric anesthesia. It's a complicated thing. Children are not small adults, we always like to say that, and no more so the case with neonates. The district hospitals are where we've got huge, that's where the real disasters are happening in pediatric anesthesia, and by training leaders who work within the public health sector in our country, and I'm South African, so I'm talking about a South African setting, but by training those leaders who set up programs, who talk and educate the people who work in their areas, who set up pathways of care for pediatric patients, and who make the areas and the hospitals in their region safe for pediatric anesthesia, that's how we're really going to impact outcomes when it comes. So when we do our next SAPSOS study and we're looking at outcomes and we're doing our next ASOS-PED study, we can see what difference has that made. But that's what we need to do in developing advanced pediatric anesthesia training. It's not that we only want people doing neonates who've done the PEDS anesthesia fellowship. There is no way we can produce enough people for that kind of thing. But we wanted to produce people who are going to make our whole system safer and who can impact that because they're coming from a position of knowledge, they've been trained in advocacy, they've been trained in leadership, and they get a seat at the table where the decisions are made so that they can change things and make things safer. So onwards with that pediatric fellowship through the CMSA. Yeah. Thank you.
And of course, that holds true for all the subspecialists. We're not picking on pediatrics specifically or cardiac or anything else. It holds true for everybody in that kind of way who needs to drive it. And I think the point is really, really well made because even in our new curriculum, the emphasis on what we're looking at creating a fit-for-purpose product at the end is not just a hotshot clinician who can put a line in their sleep. It's the other elements that you're talking about, Rebecca, to drive the system, to grow the system, to ensure that the advocacy happens and all those kinds of things. You know, we've taken the canned meds and made a Safri meds out of it for what we want to get out of it.
So very beautiful answers and comments we got from the speakers. I just want to add one more comment. Depends on what level you are talking about. So when the government is talking about general anesthesia, we have 2 points, which was very well presented by Professor Wine here. We have the issue of quantity and quality. So as anesthesiologists, we have to move away from quantity. So we want to produce a lot of general anesthesiologists, but do we have the quality? So when you are focusing on quality, that is where you're going to the subspecialization. And we cannot run away from that when we want to have safe anesthesia. So it's good you have a good number, but what is the impact on the patient life and the patient outcome? So it's very important to have subspecialty programs. And I thank you so much, Palesa, and the whole team for always bringing us together. We have seen a lot of programs happening around Africa, and it's time for Africa to stand together and improve. This is for our people. This is for our society. The people need us, and we are the brains that we are here in Africa. Thank you so much.
Good morning, everybody. Sorry.
Go ahead.
My name is Carl Gilday. I'm a community service medical officer currently practicing in rural Mpumalanga. And I think it's quite serendipitous that we have a panel that's focusing on education this morning, and now that I'm able to attend. My question to the panel, and maybe to the CMSA as well, is that 49% of community service medical officers are placed in district facilities P1 in South Africa. It's approximately 1,000 doctors, 30% of which are expected to administer anesthesia, often in very complicated scenarios with minimal to no supervision. Just an interesting statistic, 3% of community service medical officers in district have access to telephonic advice. 1.5% have access to direct supervision. So in a state of district anesthesia for our country, where almost 300 to 400 anesthetists are practicing with 2 months of experience from their internship, how do you guys propose that we maybe provide and extend education and empowerment services to our community officer anesthetists who are practicing with little to no experience and little to no supervision?
Thank you. Does anybody want to pick that up? Or?
I suggest Dean answers that question.
Sure. Thank you. Thank you. It's a difficult fight that we've been trying to put for years, especially at the university level. The South African Committee of Deans is a body formed from all the deans across the universities. And only in the last period has there been a better collaboration amongst them about what happens in the undergraduate training. At the moment, the undergraduate training is very variable, right, across the country. There are some programs that have a spiral model where undergraduates come at different times in 2 different years. Some places get an undergraduate for 2 weeks. And we've been trying to push that period of exposure in terms of skill acquisition. The one issue that did happen with the change in the internship was the lengthening from 2 weeks to 2 months for anesthesia training. But as you point out, that's nowhere near enough of what we need to happen. So the one aim is to look at how the undergraduate training is happening, and even at our university in the UKZN, there's a change in that curriculum, which is again being informed of not just coming to theatre for 2 weeks and learning anesthesia, but that needs to be spread across a broader time of your training and exposing people at the right time in their training as well. So that process, I expect, would happen more aggressively across the country. In internship, there's also a discussion that is happening about how that training can happen better, because the skills that somebody needs on day one as a community service officer out in the sticks has to be wide. You might need to deliver a baby, you might need to intubate a difficult airway, you might need to anesthetize somebody. So that exposure needs to be broader. One of the things that does need to happen better is from the Department of Health's structural system on paper. It looks fantastic, where you've got every district hospital is meant to be linked to a regional hospital, which is meant to kind of oversee that. You smiling because you know as well as I do that that doesn't happen anywhere as near as it should. So that's a problem. And the one other area which has been very progressive in trying to take this forward has been family medicine, because they, of course, are the only full-time specialists at a district hospital. But even there's a challenge because they don't have enough numbers to do that. So the exposure of family physicians to anesthesia has been happening. That's built in as part of their curriculum. So they are doing or getting an anesthetic rotation during their training for family medicine. So there are a number of attempts like that to do it. But again, I don't have a solution of saying what it is. What I'd like to have open for a comm service person out in the sticks is to be able to turn to somebody. So whether it's the local academic department, the nearest regional hospital, a specialist somewhere, some sort of link needs to happen. The one other thing which was rather disappointing for the country as a whole is in the national plan, there was a district clinical team that was being developed across the country. And that was meant to kind of coordinate the services that you're talking about. One of which on that team was meant to be an anesthetic specialist. The last time I checked, I think out of the 50-odd district programs that were being developed, only 2 anesthetic posts were filled. And those teams included a specialist pediatrician, a specialist obstetrician, specialist a family physician, a nurse practitioner, and an anesthesiologist, and only 2 because we couldn't fill those posts. So that program hasn't really, or anyway nearly, has worked as well as it was designed to. Maybe 1 or 2 across the country were actually working in that kind of way. So it remains a challenge. I think we do need to look at how we can close that loop of the network and make the contact between an isolated comm service person out there and the nearest port of call being a specialist. That's great. I think that we should pick up the conversation with SASA as well, so we can actually drive that. The facility for DA training remotely is in existence already, so we have created that mechanism by which people can do that. Are there any other questions? Any other comments people would like to make? Yeah, there. Mpoki.
Oh, thank you very much. Most of the countries in Africa, south of Sahara, north of Limpopo, have been independent for more than 60 years. We've come of age to know the burden of diseases, and so the question of whether we need a specialist or super specialist training really isn't going to be pushed or pulled. Each country will have their own factors, and those should drive the agenda of training the manpower, the human resource for health. The last question, I just want to supplement by saying that knowledge has no substitute. You either know or you don't, and we don't experiment on human beings. Please make reference to centers that can offer qualified quality services to patients that come to you. But I want to share with this audience a little illustration from the region that sees the work of our college, CANEXA, East Central and Southern Africa Health Community. In the year 2012, the Ministers of Health organized a medical surgical camp that was made to take place in Lesotho. Several specialists were collected from all the EXA member countries and beyond. We went to Lesotho and addressed challenging health conditions that locals could not bridge the gap. That was South-South cooperation. The following year, we went to Eswatini. We did the same thing, saving lots of money in government coffers. The third, and which unfortunately was the last, we went to Malawi. We did a similar thing. From various countries, various specialties, anesthesia included, for both adult, the SALU, and the little ones. We did a very, very fantastic job. It's on record. We have the means in Africa. All we need is to open our ears, our eyes, and reach out. The Red Cross facility that has trained so many people, the work that is being done by the University of Nairobi, and now PATA is coming in, and we are going to be having a serious conversation after this meeting on how the two, that PATA and CANEXA, can work in a way that we can bridge this gap. Because we cannot run 2 horses on the same race. Our race here is providing equitable access facilities for our people who are sick, and anesthesia must be leading the cause. Pain management, obstetric anesthesia, pediatric anesthesia, critical care, these are specialties that are in very, very short supply in our countries. Diseases don't choose when to come, and we are always talking about patients, but remember, you and I are potential patients. We need to strategize ahead of time before we fall sick.
Thank you very much, Mpoki. And again, Connexa, another example of going back to the C word, collaboration. And one of my most prized honors is having received an honorary fellowship from Connexa. So that points to the collaboration that happens in this space. All right, an opportune moment for me to bring this to a close, and maybe just to leave you with one last thought, another quote from Mahatma Gandhi. You should live every day like it's your last, but you should learn like you're going to live forever. Thank you.
Watching in slow motion